Welcome back everyone. I will be talking in this presentation about assessment of intestine by ultrasound in neonates. I have three main objectives for discussion. First, I will discuss the anatomy of bowel and how to differentiate jejunum, ileum, and colon. Then I will discuss the normal patterns of intestinal ultrasound and the specific markers of ultrasound in necrotizing colitis. And I have some case scenarios for discussion. Before talking about intestinal ultrasound, I have to clarify the watershed areas of the intestine. Any area in the body receiving blood supply from two different arteries, and in fact it is receiving minimal blood supply from both arteries. If one of the arteries blocked by clot or thrombus, this area will continue to receive blood from the other artery. So watershed areas are protected against thromboembolism. But if the blood supply decreased globally due to shock or ischemia, the watershed area will be the first susceptible area affected by decreased blood supply. In the intestine, there is four main areas of watershed: ileocecal area, hepatic flexure, splenic flexure, and the terminal part or the lower part of the descending colon. This slide shows how to differentiate jejunum from ileum, and the differentiation can be by detection of circularis, which giving the jejunum the thicker wall. So first of all, the jejunum is occupying the upper half of the abdomen, and the ileum is the lower half or the lower right half. Jejunum from inside is more thickened due to circularis, which is mucosal folds. So that's the jejunum from inside, and by ultrasound we can recognize like echogenic folds of mucosa inside the jejunal loop. The ileum from inside is smooth because there is very minimal circularis compared to jejunum, and the ileum from inside looks smooth compared to the jejunum. What about colon? Colon from inside and outside can be differentiated or identified as colonic hastra, presence of colonic hastra. So colonic hastra like circles or balls from inside and outside, and this can be seen by ultrasound. So that's a colonic hastra from inside and also from outside. This is a video clip of the normal locking of small bowel. So the normal small bowel is hypoechoic with peristalsis, and it can be seen as crowded loops of intestine, and even if there is artifacts of air, these artifacts can be seen moving in the clip with active peristalsis. So that's abdominal wall, and there's the loops of the small intestine, and we can see the active peristalsis in this video clip. If you are still relying on X-ray for assessment of necrotizing colitis, in fact, X-ray has only three main specific abnormalities to diagnose necrotizing colitis. First, pneumatosis intestinalis. Second, presence of portal venous gas. Third, presence of perforation. In ultrasound, we have about 11 different markers which can identify normal from abnormal looking bowel. 9 markers of them can be identified by two-dimensional ultrasound and 2 by color Doppler. Number 1, presence of free air. Ultrasound can identify presence of free air, and I will show you that when we start to discuss the case scenarios. Ultrasound can identify mural air or neomatosis intestinalis, and it can also identify presence of complex fluid, which is a late sign of necrotizing folliculitis, and presence of intraperitoneal fluid, portal venous gas, thickened bowel, thin bowel, and both of them are signs of ischemia. Thickened bowel is an early sign of ischemia, and thin bowel is a late sign of ischemia. Presence of absence of peristalsis can be identified by ultrasound, and for sure you cannot identify that by X-ray. And then the intestinal signature, and I will clarify that later in a separate slide. And we have also 2 markers by color Doppler. If we apply color Doppler 2x2 box of color, the normal looking bowel looks like separated speckles or foci of color, about 3 to 9 separated color speckles. And then we have 3 other abnormal color patterns. Can be like circles, that's a sign of hyperemia, or Y-shaped, that's also another sign of hyperemia, or zebra arrangement of color. 3 of them for sure are like very different from the normal looking color pattern. The most severe form of color Doppler, if there is no color Doppler at all, which is a sign of severe ischemia. Intestinal signature is the ability to identify the wall of the intestine as 5 different layers, and for sure you can get that in a good quality of ultrasound imaging. From inside to outside, the first layer of the intestine, that's actually a magnified lobe of small intestine. We can identify from inside to outside 5 different layers of intestine. The first layer is echogenic, which is the interface between the fluid and the lumen and the mucosa. So mucosal interface with lumen contents. That's echogenic, or bright in ultrasound. Appears bright in ultrasound. The second layer, layer number 2, is hypoechoic, or darker in ultrasound. That's like the true mucosa. And we know in ultrasound the hypoechoic layers are the layers receiving more blood, and we have the most rich 2 layers in blood supply are the mucosa and musculosa. So we have the layer number 3, which is submucosa, echogenic as well, and then the second hypoechoic layer, which is musculosa, also receiving very good blood supply. That's why appears hypoechoic or dark. And the last layer, layer number 5, is a serosa, which is echogenic. So we have the mucosal interface, echogenic, then mucosa, hypoechoic, submucosa, echogenic, musculosa, hypoechoic, and then serosa, echogenic. And we can see that as well in this video clip, like multiple lobes of ileum, and we can see the ileal wall is composed of the 5 layers. In this slide we can see 2 different types of neomatosis. In this image we have only part of the colonic wall is affected by nematosis, and nematosis in ultrasound appears like echogenic dots or foci inside the wall. And in our body, any fluid air interface appears like echogenic. So these foci is composed of air surrounded by the fluid content of the wall. That's why it appears echogenic. So part of the wall is affected by nematosis, and the rest of the wall we can see the layers, we can see the signature is clear. So only part of the wall is affected by nematosis and the rest of the wall is not affected, and there is no any other signs of necrotizing colitis. There is no any other fluids, and the bicolor Doppler was actually close to normal. And in this image we can see multiple loops of the intestine, and the signature is lost. So that's a sign of significant ischemia. So we have a loop, another loop, and third loop, and in between these loops are floating in peritoneal fluid, which is black and hypoechoic in ultrasound. And we have this loop is extensively affected by nematosis compared to other loops. The image on the left hand side showing the colonic wall, which is very thin and is measured as 0.09 centimeters. So the normal thickness of the bowel is between 0.11 to 0.26 centimeters. So that's lower than the normal average. And there is actually fluid outside the colon, which is another sign of late ischemia. On the right hand side we can see a lobe of the jejunum, which is very thickened, is measured 0.35 centimeters, which is higher than the upper limit for the normal intestinal wall thickness, which is again between 0.11 to 0.26 centimeter. So the first image is consistent with late ischemia. Thinning is a sign of late ischemia, and thickening is a sign of early ischemia. Nematosis intestinalis can be confused with air artifacts in the intestine. In the video clips we can differentiate that by active peristalsis. So on the left hand side there is area of nematosis, there is no active peristalsis, and the movement actually is my hand. I'm trying to push the air away from the intestine to see if these foci are nematosis intestinalis or artifacts. So they are staying with the pressure. In this area you can see the foci of air, the echogenic foci are like moving away, which is a sign of artifacts. And there is active peristalsis and overall normal looking hypoechoic bowel. And we should not be confused when we have pulsating peristalsis, which is abnormal kind of peristalsis due to reflected pulsation from the abdominal aorta. So the intestinal pulsation should not be considered as real peristalsis. So peristalsis should be active, and we have to see the bowel loops moving actively, not just pulsating. In the neonatal intensive care unit we have three main categories of compromised intestinal performance. The first category is necrotizing colitis, which, as you know, it's more common in preterm infants. And then we have compromised oxygen delivery. If the intestine exposed to hypoxia or ischemia due to severe anemia or severe hypoxemia, like in congenital heart diseases, or shock, hypoxic ischemic encephalopathy. And the third category, intestinal obstruction. Intestinal obstruction can be associated with compromised blood flow, like volvulus, which should be considered as surgical emergency. But obstruction can be also considered with normal blood flow. So our approach is helpful to assess all of these three categories. And in our presentation we'll focus more on the necrotizing enterocolitis. Now I have some case scenarios for discussion. Case number 1, preterm 26 weeks, post-menstrual age of 31 weeks. He developed abdominal distension, coffee ground aspirate. He's on mechanical ventilation, ECVG, failed extubation due to apneas. Acceptable blood gases, unremarkable lab work, lactate of 1.9, CRB of 7, WC's count of 9.6, hemoglobin 109, platelet count of 146. And I have this X-ray. So what do you think? Is this X-ray consistent with necrotizing enterocolitis? When I presented this X-ray, almost 90% of the neonatologists and radiologists reported this X-ray or comment on this X-ray as pneumatosis because of this area of hyper translucencies, which could be in the bowel wall. But when we performed ultrasound, and this ultrasound exactly at the same area of concern, the intestine was normal, peristalsis normal, hypoechoic. There was no any pneumatosis intestinalis, and the color Doppler was normal in all abdominal regions. So we restarted feeding with good tolerance. So this area of concern was just stools, and you have air bubbles in the stool which making the area appears like pneumatosis. That's not true pneumatosis. Most of us are still relying on Bell's classification for diagnosis or staging of neck. In this case, if we rely only in the X-ray plus clinical presentation, we would consider this case as stage 2A. But after applying ultrasound techniques, we excluded this case from being treated as neck, and we restarted feeding, and no antibiotics, no other interventions considered. Case number 2, preterm 26 weeks, post-menstrual age of 29 plus 3, presented with abdominal distension, coffee ground emesis, stable hemodynamics, WBC's count of 12.9, platelet count of 74, lactate of 0.9, CRB of 37, and no bacteremia. This is the X-ray which was reported by the radiologist as no specific sign of neck, no pneumatosis, no perforation. But when we performed ultrasound, we found significant echogenicity of the bowel. There is no active peristalsis. It was complex fluid. You can see the abdominal wall, and below the abdominal wall we have black or hypoechoic area of fluid, septated, which is a sign of complex fluid. By color Doppler, significant hyperemia alternating with areas of ischemia, absent color Doppler. So you can recognize Y-shaped pattern in the color Doppler. In this image you can see side by side normal bowel wall with maintained signature, or the musculosa can be seen, the hypoechoic musculosa with the layers. If you look close to the image you can see the 5 layers, And just beside it, you can see another lobe with extensive pneumatosis. Complications of this case were progressed to perforation with drain insertion. This infant developed a second attack of neck with hepatic abscess and peritoneal infection, and this infant stayed with prolonged course of antibiotics. And again, if you apply Bell's classification or staging, this infant initially, as per the clinical impression and the X-ray, was only consistent with stage 1A. But after applying the ultrasound, the impression totally changed to be stage 3A, and after perforation became 3B, which is the bottom of the classification. Case number 3. Preterm, 23 weeks at birth, post-menstrual age of 25 weeks. On conventional ventilation at the time of assessment. Abdominal distension with absent bowel sounds. Confirmed gram-negative sepsis for Klebsiella at the same time of assessment. Platelet count was 76, CRP 49. Stable hemodynamics with lactate of 2.2. In the X-ray, we couldn't identify any specific sign of neck, apart from paucity of bowel gas, but this is not a specific sign. As reported by the radiologist, few distended bowel loops are identified within the mid-abdominal region. No free air is identified. This cross table dorsal decubitus X-ray, just to rule out any suspicion of perforation, and this X-ray has been reported as no perforation, and the air most probably intraluminal rather than free air. So based on the clinical presentation and the X-ray, you could interpret this case as septic ileus, and you cannot rule out neck, and it's very difficult to consider surgical intervention versus medical intervention based only on the X-ray. So it will be actually difficult to select any one of these impressions. By ultrasound, we were able to see free air over the surface of the liver. So that's the liver, and there's air artifacts can be seen between this, the abdominal wall and the liver, with a parallel A-line artifact and also some B-line artifacts. So that's a sign of free air. And then we evaluated also the intestinal regions, and we found that in the right upper quadrant encysted air, which is a sign of concealed perforation. That's why the perforation was missed from the X-ray. By color Doppler, very significant hyperemia in some areas, and other areas with ischemia when there is no detected color Doppler, and you can see hyperemia was Y-shaped. Most of the jejunal areas, there was no detected peristalsis, active peristalsis, and significant increased echogenicity of the bowel wall. This is a cross section of the colon, and you can see inside the colon there is a floating tissue, which is part of the mucosa. That's sloughed mucosa of the colon. And this is the final report. And we are relying on ultrasound and near-infrared spectroscopy in our assessment, but in this presentation I just focused on ultrasound. So the final conclusion in this case, based on our assessment, was as follow. Impression of grossly abnormal and ischemic bowel with no detected peristalsis, but no evidence of gangrenous bowel because of presence of hyperemia with high oxygen extraction as detected by near-infrared spectroscopy. The right upper quadrant, encysted air is a sign of concealed perforation with minimal free air over the hepatic surface. Thinning of the descending colon walls with sloughed mucosa. Surgical drain inserted 4 days after assessment with a stool coming through it, and later on 5 fistulas open to the skin. So this case was a really late case of necrotizing enterocolitis. Removed the necrotic areas and stool from the peritoneal cavity 8 weeks later by surgery. Several trials of feeding never got to full feeds due to abdominal distension and sepsis. Withdrawal of care due to multi-organ failure at post-menstrual age of 33 weeks. And again, according to Bill's classification, based on the clinical impression and the X-ray only, the impression was just stage 1A or stage 1B at the maximum of neck, but after ultrasound, the impression moved to be at the bottom, stage 3B. Then I have case number 4, and this case will be the last case in this presentation. Preterm 26 weeks, one of twins, post-menstrual age of 33 weeks, stable on level 2 nursery on CPAP, then transferred to NICU due to frequent apneas, intubated and started antibiotics. The clinical team requested target neonatal echo to rule out PDA. CRP was less than 1, negative cultures, normal lab work, and CBC. On the echocardiography, we noticed actually that the liver is full of air. And you can see in the portal venous gas, in the portal veins, there is a gas bubbles moving everywhere in the liver. So there's a liver surface and the diaphragm, and you can see the bubbles like here moving inside the portal veins. And this is X-ray, and the X-ray actually was done after the ultrasound because there was no any suspicion of neck before echocardiography. And again, this X-ray, we cannot identify any other sign of neck other than some tracks of air in the liver, which is consistent with the portal venous gas. In this case, there was no any suspicion of neck based on the clinical assessment, but after detection of the portal venous gas by ultrasound, now we have a clear suspicion of stage 2B of neck. In our center, we are relying on both ultrasound and near-infrared spectroscopy for classification of pneumatosis as diagnosed by ultrasound. And we have 2 main categories can be identified. Transient pneumatosis colitis, which is not really necrotizing enterocolitis. Only restricted areas of pneumatosis by ultrasound. No predisposing factors like prematurity or congenital heart disease. No clinical or biomarkers of ischemia. Clinically well and usually presented with bloody stool. Normal near-infrared spectroscopy, so normal tissue perfusion or oxygenation by near-infrared spectroscopy. This category could be related to protein milk allergy. And on the other hand, we have the true necrotizing enterocolitis or ischemic bowel. And in most of these cases, we should have predisposing factors like prematurity, congenital heart disease, HIE, or severe anemia. And it is common to have inflammatory markers like CRP high in this category, or metabolic acidosis. Usually, the infant in this category looks unwell with distended abdomen and erythema of the abdominal wall, abnormal oxygen extraction by near-infrared spectroscopy. The conclusion of our presentation: assessment of intestinal performance by ultrasound is helpful, particularly in atypical cases, when the clinical impression does not match X-ray. Thank you very much.